Good morning, folks. We're getting close to the end of our sort of CME year, so to speak. We usually do that, sort of wraps up usually in June. The Swedish program in June will be an update on bariatric medicine. And I want to put a plug in for 2 weeks from now with the OMC session that we'll have. We're going to have Joe DeScala. Some of you may remember or may know that name, a local man who's actually embraced and taken over or created an organization called 4PA. And he's going to talk to us about his work in Port Angeles with homeless camps and the homeless problem in Port Angeles, and his work and his organizations to try to help clean those up. I know that's a rampant problem, particularly on the West Coast towns and cities. I think it'd be really interesting to hear Joe's discussion. And with that, then I want to welcome Dr. Kelly Paulson. She's an oncologist and immunotherapist from Swedish Providence, director of the Melanoma Clinic, as you may see there, involved with the Paul Allen Research Institute, and widely published. And it looks to me like on her bio also has, quite a bit of also some emphasis on some holistic sort of parallel approaches to these treatments. And welcome, Dr. Paulson, and thanks for joining us this morning.
Thank you very much for having me this morning and for joining. I'm excited to meet you all electronically. I have some contact information on the last slide, and so if you ever have any questions about a skin cancer patient or another patient who you think might be eligible for cancer immunotherapy, I'm always happy to touch base, or any questions about our Paul G. Allen Research Center resources that we do make available within the Swedish network. So we've got a number of different granting opportunities, both small and large, and we're happy to talk to you more about those. Did my slides advance?
Yes.
Okay, so unfortunately, no conflicts of interest. Our objectives today are we're going to talk about advanced skin cancers, melanomas, and other advanced skin cancers like squamous and basals. We're going to talk about which patients are most appropriate for referrals into specialty services, and we're going to talk a little bit about emerging therapies for skin cancers. You might have some of those patients coming to you and saying, well, what about the melanoma vaccine? So skin is important. There's 10 pounds of it in all of us, with more than 300 million cells, all of which are constantly regenerating themselves. The fundamental job of skin is to protect us from the insults of the world, and those include things like heat and cold, infection, trauma, chemicals, and the world's largest source of natural radiation, which is UV sunlight. Because the skin is constantly being assaulted, it has a very high cancer risk. The DNA in the skin is exposed, the cells are growing rapidly, and that is a setup for skin cancer. Skin actually has a lot of mechanisms in place to protect itself against cancer. So melanin, which is the pigment, it helps to protect cells against UV, and the body has a really interesting setup for delivering melanin to the skin cells, which we'll talk about in a moment. There's also DNA repair proteins that are very upregulated in skin, and they help to reverse this constant damage that comes from UV sunlight. One fun fact is that, caffeine really synergizes with the body's DNA repair systems to help eliminate skin cancer cells through a process called synthetic lethality. And it doesn't matter how you get that caffeine. Of course, I'm being in Seattle, I've shown you a nice cup of coffee here. But caffeine intake does reduce your chance of skin cancer, particularly the non-melanoma skin cancers, but also melanoma to some extent, and wrinkles as well. And then finally, one of the most important components in helping the body to defend against skin cancer is our own immune system, particularly our adaptive immune system with T cells, CD8 T cells. And these help to identify and eradicate UV damaged cells before they have the opportunity to turn into cancer. That pigment protection against UV sunlight comes from a cell called a melanocyte. It's really an interesting setup for defending the body against sunlight. One of the features of a melanocyte is so the skin cells themselves don't make pigment. All of the pigment gets made by the melanocyte, and the melanocyte delivers the pigment with these tentacles out to all of the skin cells around. And those tentacles are what give the cancers that come from the melanocytes, or the precursors to the melanocytes, the melanomas, that potential and propensity to spread. And that is the reason why when people have a squamous cell carcinoma or a basal cell carcinoma, we're really able to get a tight margin on that tumor, eradicate it with Mohs surgery, get the edge, and you're done. Whereas with a melanoma, patients are like, well, why did I get a shark bite here on my arm to remove that melanoma tumor? And that's because of the nature of the melanocyte stretching and spreading. That is also why melanoma is more likely to spread through lymph and through blood. So skin cancer is a problem in Washington. So Washington State has a very high melanoma rate nationally. There are a lot of people that have gotten sunburned. And this is probably not going to come as a surprise to you out on the peninsula. But you can see here on this slide that melanoma is highest, as shown by this red color, as are other skin cancers in the peninsula compared to just about any other place in the state of Washington.
Okay.
And so for this reason, you're going to see a lot of skin cancers in your patient population. This is something that you are likely to come across clinically, and something that you should be aware of and attentive to within your practices. When looking at a lesion with concerns for melanoma, so we look for the A, B, C, D, E features, which many of you know well. So lesions that are irregular, lesions that have borders that are indistinct, lesions that have a lack of uniformity in color, or the color is extremely different than everything else in the body. If all the spots are brown and one is black, that is concerning, although you can have amelanotic melanomas as well. Lesions that are very large, although it is the thickness rather than that horizontal spread that determines how bad a melanoma is. And again, that's because the normal job of a melanoma is to, or melanocyte, is to stretch out flat and touch a lot of things. And then finally, if a lesion is changing, evolving, particularly if it's blistering, bleeding, otherwise causing problems or changes over time. One of the tricky things is, of course, all our patients come to us all the time with their seborrheic keratoses, which are wisdom spots or barnacles. They are not melanoma. They meet many of these features. And sometimes it can be tricky to determine, whether one's a seb-K or melanoma, although, again, looking for that waxy stuck-on appearance can help to differentiate these from melanomas. So the overall impact of melanoma and other skin cancers have been increasing. All cancers, as shown by the blue line, we're actually making some progress there, partly due to the progress on smoking and also cancer detection and prevention with colonoscopy and mammogram. However, unlike all cancers in general, the rate of invasive melanoma, so stage 1 or higher melanoma, which is shown by the green line, has rapidly increased over the last 2 decades. That is true in our state as well. So this is now not looking at rates, which is age and population adjusted, but number of cases, which also takes into account our growing older population. And when we look at the number of melanoma cases by year diagnosed in the state of Washington, you can see that both invasive in the green line and in situ in the blue line have rapidly increased over the last 30 years. And we now have about 5,000 melanomas diagnosed each year in the state of Washington, about half of which are invasive. Again, melanoma is going to be swamped in terms of the number of diagnostic cases by the non-melanoma skin cancers, our squamous cell carcinomas and basal cell carcinomas. However, given the sheer number of the squamous cell carcinomas and basal cell carcinomas, they are not captured by our cancer registries, even when they are advanced and invasive. And so for this reason, we use melanoma as an indicator of our total skin cancer burden. When we look at the percent of invasive cancers that are melanoma in the state of Washington, that has also been increasing. It has more than doubled. Now about 1 in every 15 to 1 in every 12 cancers in the state of Washington will be a melanoma. There are some steps that we can take to help prevent and detect melanoma early. One important thing is avoiding sunburns, and that's really important from an early age. So those of you that are touching a pediatric population, remembering to advise and counsel on those hats, sun protective shirts, sunblocks, and really avoiding those early sunburns, particularly in the pediatric, teenage, young adult years. Hand in hand with that is tanning bed avoidance. Tanning beds are very bad. They greatly increase the melanoma risk. We allow our young people to be exposed time and time again to this carcinogen, and we really need to counsel our adolescent patients to avoid tanning beds. Finally, in the past couple of decades, we've been able to show that sunscreen works. Australia led the way in showing us this. They have a lot of melanoma in Australia. Fair-skinned population moved to a different part of the world where they don't get exposed, and there's a great big hole in the ozone layer. Australia has a very high rate of skin cancers. And for that reason, the government in Australia has really put forward all of these efforts in terms of sun protection and skin cancer prevention campaigns. In Australia, they have this 5-part method, the slips. Put on a shirt, slap on some sunscreen, slap on a hat, seek the shade, and slide on your sunglasses. And with this, they've really been able to show a decrease in the melanoma incidence over time. Finally, screening has been shown to be really important for patients that are at high risk of melanoma. Either melanoma or non-melanoma skin cancers, those that are immune suppressed, those that are BRCA and other risk mutation carriers. One bright spot in melanoma care recently has been that the millennial and the exennial, whatever the new one after the millennial is, those generations actually have falling melanoma incidence. So this is looking at the annual percentage change in melanoma incidence rates in the United States between 2006 and 2015. Again, over that period of time, the overall burden of melanoma dramatically increased, with the largest component of that being a large increase in the number of cases in the baby boomer generation. But looking at the incidence rates, while the incidence rates rose dramatically over that period of time in a very statistically and clinically significant manner for those over the age of 50. When we looked at adolescents and young adults, we saw that the melanoma incidence fell dramatically. That was not true of the youngest pediatric population, where we really think of different causes for melanoma beyond sunlight UV damage. But the adolescents and young adults had a much lower rate of melanoma. We like to think that this is, sun protection, sunscreens, all of those things. It is certainly possible that it is more indoor time with electronics. But for whatever, societal reasons, we are seeing decreased melanoma incidence in young people, which is a wonderful trend. And we hope to see this sustain and continue as that cohort gains wisdom. So early melanomas, stage 1 cutaneous melanomas. So stage 1A patients, a thin melanoma. Again, it is not the side-to-side size, but how thick or thin the melanoma is that gives it the potential spread, have more than 98% chance of cure. For this reason, there is no routine role for laboratory imaging studies for an asymptomatic patient with a 1A melanoma. Now, because there is a lot of melanoma out there, it is likely that at some point in your practice, you will encounter the person that has a 1A melanoma that comes back at some point in the future. But the risk of exposing so many people to the radiation of a routine baseline scan with the low rate of detecting spread at the time of diagnosis means that baseline scans for asymptomatic people are not particularly useful for staging melanoma for an early stage thin melanoma. It is important that we get a thorough lymph node exam, a thorough clinical lymph node exam at the time that we evaluate people. And there are some people who require scans for initial staging of their nodes, whether that's ultrasound of the nodes or CT of the nodes, because the habitus really prevents us from getting a proper lymph node exam. So there are some exceptions to this rule, but by and large, we should not be getting scans on people with 1A melanoma, and we particularly should not be getting PET CT scans with a high level of radiation that they entail. A second bright spot in melanoma has really been adjuvant therapy in stage 2 and stage 3 melanomas. So when a melanoma starts to get a little bit thicker, the risk of that melanoma coming back all of a sudden gets much higher. And this is true even of thick melanomas that have not spread to the lymph node. So stage 2B and stage 2C melanoma, they're not there. They haven't spread at the time of diagnosis, but they're thick. They might be ulcerated. They're highly mitotic. And those patients, even though the melanoma was adequately resected with their giant shark bite surgery, had a really high chance of recurrence, particularly because many of these patients are young, and the highest risk factor for them are really the melanoma. So what it functionally meant was that for many patients with stage 2 melanoma, their melanoma, despite being resected, was the most active medical issue. For a long time, the only medications that we had available to reduce the chance of this coming back were interferons, which were extremely toxic. We tried radiation to reduce the chance of the melanomas coming back, and that doesn't work because melanoma is inherently radiation resistant. The whole job of the melanocyte is to defend the body against UV radiation. Radiation is not a very effective way of fighting melanoma. We use it in certain circumstances in very concentrated ways like CyberKnife. But by and large, radiation is not helpful at reducing the chance of melanoma coming back. We have developed immunotherapies that were initially tested in the metastatic setting that impact the immune checkpoints. And I'm going to talk a little bit about the PD-1 checkpoint, although other checkpoints come into play with melanoma. There are now 3 that we target. And these are really the signals that the body uses to prevent autoimmunity. And so with any interaction between a cancer-fighting immune cell, the T cell, and a cancer cell, there are 2 interactions. And so you can think about it, this T cell, it carries a lot of things with it that allow it to kill the cells that it interacts with, right? Because its job is to kill virus-infected cells and cancer cells. And so it could be dangerous if there were not regulations or switches on those types of cells. So it is almost like a gun in that each of these T cells has a trigger switch, which is the T cell receptor that the T cell uses to identify the problem cell. And each T cell receptor is specific and unique and looking for a specific and unique thing. And the way that the body does this is fascinating and far beyond the time that we have in this presentation, but also has a safety switch, a checkpoint. And this is where these PD-1, which is on the T cell, and PD-L1, which is on the cancer cell, or the immune cells in the microenvironment next to the cancer cell, really engage this safety switch. And so cancer is tricky. It wants to hide from the immune system. And one of the ways it does this is by putting up the safeties. It says, hey, don't kill me. I'm fine. Tire out, go away. I'm fine. Here's, put your safeties on. And so we have these drugs that inhibit this safety switch, and they allow those T cells that pre-exist, that recognize the cancer, to go in and kill the cancer cells. We knew that they were effective for stage 4 melanoma, and so we went and tested them in earlier stage melanomas, and we've learned that in high risk stage 2 melanoma, getting a year of adjuvant immunotherapy, and in this case, the brand is pembrolizumab, which, there are 8 different drugs that essentially do the same thing. They are all individually labeled. They are not generic. They all cost the exact same price. Anyway, the drug that was tested in this particular context was pembrolizumab. This drug was shown that for patients with 2B and 2C, so high risk stage 2 in the skin, has not spread to the lymph node, that there was a pretty significant improvement in recurrence-free survival, the chance that melanoma comes back. This data has now been extended, and these curves are further separating over time, and there's starting to be an overall survival change. And so really there is a practice change here, which is that stage 2 patients who previously were not always seeing medical oncology because what we had to offer for medical oncology was not very good with interferon, should now really be meeting medical oncology in addition to meeting a surgeon to talk about whether or not adjuvant pembrolizumab makes sense in that case. Now, there are some patients who may have clinical risk factors, comorbidities, autoimmune disease, other competing medical risks for whom adjuvant immunotherapy may not make sense. There are other patients whom improving the recurrence-free survival, the melanoma is their highest risk lesion, so it makes a lot of sense. Right now, the guidelines are mixed in terms of how strongly they recommend adjuvant immunotherapy, but all of them recommend a discussion. The NCCN, which is probably the most preeminent guideline, does give a category 1 recommendation for adjuvant immunotherapy in this context, but on a practical level, many patients are electing against choosing to do this, although they should all get the benefit of the conversation. Now moving on to stage 3 melanomas. This is melanoma that has spread to the lymph nodes. The survival from a melanoma standpoint in stage 3 melanoma is dramatically different from those patients who have melanoma in just a tiny amount that's not clinically detectable in the lymph node, to those where we can feel a big bulky lymph node under the arm or in the groin or those pieces. So although there is stage 3 melanoma, the way that we counsel and monitor a patient with stage 3A melanoma is going to be dramatically different than what we do for a stage 3D melanoma. Once melanoma is in the lymph node, we definitely need staging. Okay, so even in asymptomatic patients, now we've crossed that threshold. We're getting our scans as more likely to be useful than not. And so most of these patients are going to need a whole body, arms and legs. Okay, melanoma likes to metastasize to skin and bones, in addition to brain and liver. And nodes. And so these are the patients who getting that whole body PET CT and the brain MRI is going to be helpful for us in understanding how much melanoma they have at the time of presentation. In 2023, stage 4 melanoma can be curable under many circumstances. So doing this imaging does not help us understand whether it's curable or not, but helps us understand the best way to approach this patient with curative intent. Is this person someone who's going to need surgery and 1 drug immunotherapy, or is this a person who needs dual immunotherapy? There are a couple bright spots in stage 3 melanoma. The first is these early stage 3 melanomas where you cannot feel the lymph node. Okay, and there have been a couple of randomized trials that have shown that stage 3 melanomas where you cannot feel and they have a low volume of melanoma in the lymph nodes, these early stage 3s, where you're sort of surprised by the sentinel lymph node biopsy that the sentinel lymph node is involved. Those patients historically went on to get lymph node dissections. So the sentinel lymph node biopsy, relatively low risk procedure, taking out only a couple of nodes that are sentinels, those draining the melanoma lesion, pretty low risk of lymphedema, very good postoperative outcomes. A completion lymph node dissection is absolutely necessary under many circumstances, but it comes with a higher rate of surgical morbidity, even with the best and greatest surgical techniques. And of course, we have fabulous surgeons that do their very best to reduce the chance of this, but there is a high rate of lymphedema or swelling in the arm, and there's a fair amount of surgical morbidity, and it also delays time to getting systemic therapy. Remember, I've just said that we have systemic therapy options in the adjuvant setting for reducing the chance of the melanoma coming back. So with these 2 randomized trials, they were able to show that close surveillance of the lymph nodes in people that had sentinel lymph node positive but not clinically appreciable lymph nodes was equivalent to doing the surgery up front. This does mean that the person needs close surveillance. So if this is somebody who is never going to show up in your clinic ever again, you might think more heavily about doing that surgery, right? If they're not someone who's going to get their adjuvant therapy or at least talk to their doctor about the adjuvant therapy, if they're not someone who's going to follow through with getting the ultrasound under the arm and their scans, you're going to be less inclined to do a close surveillance approach than somebody who you know is going to show back up. But this is a practice change within melanoma. So stage 3 patients with non-palpable lymph nodes do not need nodal dissection necessarily up front. They do need ultrasounds of nodal basins. It's been hard to integrate MSLT findings along with routine scans. What I do in practice is the first 2 years I see patients every 3 months, and I alternate those visits between an ultrasound of the lymph node and a CT scan. And so every 3 months they're getting a look-see, and so that gets you out of the doing the ultrasounds every 4 and the scans every 6. It just helps make it clinically functional. There is a variation in how people are implementing this in the real world. When I talk to other melanoma oncologists, they seem to be doing similar things, but we're hopeful that there will be more guidance in our guidelines about how to actually implement this in the real world moving forward. Okay, again, with stage 3 melanoma, we see that the anti-PD-1 drugs help increase our rate of melanoma cure. Again, I'm showing you the same drug, pembrolizumab. However, nivolumab also has data in this setting. Again, we are seeing a dramatic increase in the number of people who do not have their melanoma come back. There was a relatively surprising finding related to this earlier this year. And this relates now not to people with early stage melanoma that you can't feel, but instead people that have palpable melanoma in the lymph nodes or otherwise clinically appreciable lymph nodes. And it deals with the way that we approach these patients. Historically, we took these people directly to the operating room. We took their, assuming their staging was clear elsewhere, we took their melanoma out, we took their lymph nodes out, and then we went on to do our adjuvant or after surgery immunotherapy. There was a randomized controlled trial that came out earlier this year in the New England Journal. It was a SWOG study, and it randomized people from getting all 17 doses of their immunotherapy. It's every 3 weeks, so that's a year. It's the pembrolizumab for this particular study, although the findings are probably true for the other brands, right? These drugs are extremely similar to one another. And they randomized people to getting all of their immunotherapy after their surgery, or to getting 3 doses of their immunotherapy before their surgery. And the goal of this study was to show that the surgery was easier if you had treated the melanoma a little bit beforehand. But what they found was not only that the surgery was easier if you had treated the melanoma beforehand, but they saw a markedly different outcome in terms of the chance that the melanoma comes back with the people that got their immunotherapy while the melanoma was still in place and the body had antigens or immunogenic parts of the tumor to see. And this was pretty clinically significant. It is a randomized control study. The guidelines are still determining how strongly to recommend this. You know, certainly all of them say to do neoadjuvant in a clinical trial setting. NCCN is pushing it more heavily than some of the others right now in terms of doing this as part of standard clinical care. Anyone that has any question of, surgical morbidity, you would lean towards doing a neoadjuvant approach if they did not have contraindications to immune therapy. And frankly, a lot of discussion in the guidelines is related around what happens if you give them 3 doses and there's nothing there at the time of surgery. Do you still do the other 14? Functionally, in real world practice, until I see data, otherwise I still am, as long as the person is not having any complications of their therapy. This data is very, very new. It came out in the New England Journal last month. But I expect to see a big shift in the way that melanomas are approached when they have palpable lymph nodes at the time of diagnosis. And functionally, this did include resectable stage 4s as well. And functionally, if you have a patient who has an advanced melanoma that you're considering surgery for, you should be getting a medical oncology consult early to help decide the best multidisciplinary approach to that melanoma. In the stage 3 setting, the BRAF and MEK inhibitor pills also work. The dabrafenib and trametinib is the most commonly employed pair in the stage 3 setting because that's the one that was studied. The encorafenib binimetinib was not studied for stage 3 melanomas and won't be because we have randomized data comparing to placebo, and that trial will never happen again. If people are having toxicity to the dabrafenib and trametinib or drug interactions with the dabrafenib and trametinib, both of which are more common than with the encorafenib binimetinib, it would be reasonable to substitute encorafenib and binimetinib as long as you're justifying the rationale for the switch in the drugs. So these pills work for melanomas that carry a BRAF mutation. The most common of those is the V600E. We preferentially use immunotherapy over the pills, both for toxicity and cost to the patient concerns. The overall drug cost is similar. The out-of-pocket cost tends to be a lot higher for patients with the pills. The thought that immunotherapy gives a better potential for long-term control. However, there is not head-to-head data comparing immunotherapy and BRAF MEK inhibitor approaches. And either are reasonable, and certainly the BRAF MEK inhibitors are the way to go if somebody has a high risk factor for immunotherapy and a BRAF mutant melanoma, such as carrying underlying autoimmune disease. Now moving into stage 4 melanoma. So this is melanoma that has spread through the blood. I know that there are only a few folks on the call from a medical oncology standpoint, so I'm not going to spend too long on this, but I did want to talk a little bit about just what outcomes look like and what approaches look like for this. So in 2010, this was a terrible, terrible disease and everybody died. As we move into the 2020s, we now are able to save about half of patients with stage 4 or widely metastatic melanoma, which is not nearly the number I want it to be, but is a lot better than the number where we were. That is largely through progress in immunotherapies, although targeted therapies have a role as well. The big news in 2022 was we got a lot of updated data on what we call dual immunotherapy, meaning that patients were treated up front with not only the nivolumab or pembrolizumab, the one drug alone with immunotherapy, but with a second immune checkpoint inhibitor, now targeting the CTLA-4 checkpoint. That is where the T cell that sees the tumor talks to its friends in the lymph nodes. We've learned that the ipilimumab and nivolumab combination appears to significantly extend overall survival when given upfront as compared to one drug alone. Again, the 5-year metastatic melanoma survival in these studies is exceeding 50%. It's wonderful that we're saving these folks. But again, not as high as we want it to be. And we'll talk a little bit about how we're going to try and make that higher. It is an effective but often toxic regimen, so there is a high rate of immune-mediated side effects with this regimen. If people are coming on this regimen and they're coming into your ERs, you have to think about all sorts of strange and crazy things. And the thing that happens emergently the most, that gets missed the most, is something called hypophysitis, where basically you get pan-hypopituitarism. And it's really important that if someone is coming in and they're profoundly hypothyroid from their hypophysitis, that you check them for adrenal insufficiency that's central as well, because you have to replete the steroids first before you replete the thyroid, and actually functionally just go ahead and give that person both upfront at once if they're coming in and they're sick and they're on these regimens. If somebody is on the ipilimumab and nivolumab conversation and you are not a medical oncologist and that person is coming in with something new and different, that is a person who you should uniformly be talking to medical oncology about. This is a high-risk regimen with a 30 to 50% chance of life-threatening side effects and all sorts of strange, unusual, and unpredictable side effects. It is a life-saving regimen, so we give it, but it is one where we talk to our patients closely about the fact that they can get strange strange things, and those strange things can happen anytime. It's different than what we're used to seeing with something like a chemotherapy, where the side effects are predictable and often happen after the first dose. These are very, very unpredictable and often happen after the second, third, fourth, or fifth dose, and they may not happen at a time that is near a dose. So the drugs are given every 3 weeks apart. Usually we're not used to people seeing people come in with new chemo side effects, you know, at 1.5 weeks after they were dosed. Here you absolutely can see it, where they were fine one day and the next they got severe autoimmune hepatitis from the drugs. There is another dual immunotherapy that was recently FDA approved for melanoma. It's called relatlimab. It is less toxic than ipilimumab. It improves progression-free survival compared to nivolumab alone. The overall survival data is currently immature. Functionally, this checkpoint is now working back on the T cell and the tumor cell, so it's a second safety switch that is there. The drug is packaged along with nivolumab. It is given on a monthly basis. It is extraordinarily expensive. It is on the order of $800,000 a year. So I look forward to seeing cost effectiveness data on this drug. It does appear to improve progression-free survival compared to nivo alone, and those curves continue to be further apart as the data matures. So we're going to learn more about how to use this. Because ipilimumab and nivolumab has that long-term overall survival data, for patients that are candidates for ipilimumab and nivolumab, we're leaning towards using that first. And I tend to do IPI-1, which is the lower dose of ipilimumab, and nivolumab 3, unless somebody has brain metastases or another reason to go to that higher dose of IPI. And that's an area where we're always happy to talk to you. If you're a medical oncologist and you want to talk about IPI-NIVO dosing, please, I'm going to give you my cell phone at the end of the slide. Please reach out. I'm happy to talk to you about it, walk you through it. If you'd like, I can see the patient in a virtual or in-person second opinion, or I can just provide you advice. But any of your melanoma questions, I'm happy to answer. We also have BRAF and MEK inhibitors in the stage 4 metastatic setting, and we have some targeted therapies as well for other mutations. So the most common other one is KIT, where we get Gleevec to work on the KIT mutations, and we tell the patients to purchase the Gleevec from the Mark Cuban drug company, who sells it for $99 for a 3-month supply. The BRAF and MEK inhibitors, there's 3 different brands of it. There's encorafenib, binimetinib, dabrafenib, trametinib, and vemurafenib and cobimetinib. The first 2 pairs we use more commonly due to the side effect profile of the third. These patients are at higher risk for heart failure, and so just be aware of that if they're coming in with new heart failure symptoms. There is a new systemic therapy that is out on the wings for melanoma. It is likely, although not guaranteed, to be FDA approved in November of this year. We don't know the exact time frame of that, but it is currently under FDA approved. This is a tumor infiltrating lymphocyte therapy. The name of the drug is called Lifalusil-T. It is a very complex therapy. First, the patient, and this is for patients who are having relapsed refractory melanoma that has progressed upon our standard therapies. If you have a BRAF mutant patient who, or patient carrying a BRAF mutated melanoma who has progressed through IPI-NIVO and is currently responding to BRAF MEK inhibitors, this is somebody to be talking about medical oncology at one of the bigger centers early about, because of this drug becoming available, and because we're going to want to be able to move relatively quickly when that person progresses due to the pace of BRAF MEK melanoma, mutant melanoma progression when it occurs. How this therapy works is, first, a tumor is resected. It is sent back to the company, and the company that makes this is named Iovance. And there, the T cells, the cancer-fighting immune cells, are expanded back in the laboratory. So it's the patient's own immune cells. Once those are prepared, the product is shipped back, and the patient undergoes lymphodepletion, meaning they receive chemotherapy. This a standard cytotoxic chemotherapy. We don't use it for melanoma anymore functionally, but we do use it in this circumstance not to fight the melanoma, but to make space in the bone marrow for the T cells to go, and also to help the body make cytokines to promote the expansion of the tumor infiltrating lymphocytes once they're infused. After the person is lymphodepleted, there's space for these new T cells coming in. They receive the T cells, and then they receive IL-2 at high doses, up to 6 of them. So this is an inpatient therapy. The person is sick, and it is a high-risk, high-reward therapy. This is a therapy that really can only be delivered at specialized centers due to the nature and intensive pieces of it. It is, how it integrates with CAR T teams and those types of things is getting sorted out at all these institutions, but we are enthusiastic and eager for this to be clinically available for our patients. The reported data on this therapy is striking. So this is data that was published about 2 years ago. A lot of the delay in terms of getting out to clinical practice really has to do with, expansion of manufacturer capabilities. And these are patients with heavily refractory melanomas, and each patient is indicated by a line, and a line going down it means that their tumors improved. And you can see that that quite a number of patients treated with this therapy had improvement in their melanomas, although complete responses, as shown by the green lines, were rare. Importantly, many of these responses have been very durable and have been reported to last for a long time. And so this is a therapy that appears to not only shrink the melanoma, but potentially have curative intent. And we know from NIH studies of the NIH TIL, which are a different product, that TIL was curative in many of those patients. So they're patients that received TIL 20 years ago, still in remission. And so we're all very excited for this modality to be available for melanoma care. Due to the intensity of it, as well as the data, in the clinical, in frontline, this is only going to be used in clinical trial setting. And again, in your day-to-day practice, this is going to be in the relapsed refractory setting. I want to briefly touch on the melanoma vaccine because there's a lot of press on it. So this vaccine is made with the mRNA technology that was used for the COVID vaccine. It has been tested in stage 3 melanomas, so melanomas in the lymph node that have been resected, and that person was receiving pembrolizumab immunotherapy, and it is tested as an add-on. Unlike the COVID vaccine, where everyone gets the same thing, each mRNA vaccine is custom. So the company went ahead and sequenced the melanoma tumor, predicted which DNA mutations in the melanoma tumor might be recognized by the immune system, and made a custom vaccine for each person. So everyone gets their own vaccine based specifically on their tumor, personalized medicine. So, this has been a pipe dream of oncology for a long time. This trial is very early. They had 50 people in the control arm and 100 people about in the intervention arm, I think 107. And it only has really been presented in very early phases, in terms of follow-up. There was a clinically and statistically meaningful improvement in melanoma outcomes in the persons that received the vaccine as compared to the persons that did not. And we enthusiastically look forward to the expansion of these clinical trials and the testing of these approaches in other therapies. Right now, the vaccine is only available under investigational settings, and the phase 3 study hasn't ruled out, so we're in a little gap in terms of availability. As soon as the studies are open, I'll communicate back out because patients are very, very motivated for this. One of the things that's going to happen is I believe stage 2 patients are going to be eligible for the phase 3 study. So we don't know a lot about it yet, but we are excited for that potential as well. I want to briefly touch on a big update in non-melanoma skin cancer. So cutaneous squamous cell carcinomas are a lot more frequent. Most of the time, those can be resected with a surgical procedure, perhaps a bedside procedure, perhaps a Mohs, perhaps the surgeon taking to the operating room, depending on the size and location of the tumor. Sometimes, unfortunately, cutaneous squamous cell carcinomas get quite advanced, whether it's relative to underlying risk factors, a high risk of disease, or neglect, if it's in a location or the patient has other medical circumstances that lead to a delayed diagnosis. So, all of those things can lead to the advanced presentation of cutaneous squamous cell carcinomas. There is a different brand of checkpoint inhibitor named cemiplimab. And they tested this in a neoadjuvant before surgery setting, where they gave 4 doses of the cemiplimab 3 weeks apart for patients in whom the surgery would be extremely morbid. Again, here each line going down was a patient that had shrinkage of their tumor clinically. But importantly, the dark green lines are the patients in whom at the time of surgery, there was no residual squamous cell carcinoma. So now I think we're evaluating, how much surgery do these folks need? But if you have a surgery that's going to be extremely morbid for a cutaneous squamous cell carcinoma, strongly consider working with your wonderful medical oncology colleagues out on the peninsula. I know Dr. Palmer well because we got to work together for a few years in Edmonds before he went over to the sunny side to be closer to home. They're great folks, and so you should really think about using this drug in this circumstance. It's been really helpful. We think in some cases this is going to be radiation sparing as well, which can be a helpful functional consideration for patients where getting to radiation can be challenging. I think we don't have a good, we don't have consensus opinions on how to handle pathologic complete response right now, but I feel a lot more comfortable about omitting radiation in that circumstance than I do a patient that receives surgery alone. I really want to thank the CME team and for all of you for your time and attention in letting me give this presentation today. I want to thank my boss, Dr. Sarah Jo Grathline. I want to thank the Swedish research team, particularly Dr. Phil Gold, Yvonne Lackey, and Sam and Andrew, and Christina, who helped with the immunotherapy trials. I'd love to thank my colleagues in melanoma group at Swedish Cancer Institute from the MedOnc standpoint. So Ben and Min, I'm extremely grateful for their participation in the program and for having a vibrant melanoma program in all 3 sites. I still collaborate closely with the Fred Hutch Melanoma Group, and so I'm very appreciative to the folks there. And of course, all of my colleagues from other specialties, patients, family members, and I'd like to thank you all for your time and attention.